This lesson is talking about gas exchange and oxygenation. It's giving you all a picture of the different structures of the respiratory system. And the different structures of the respiratory system. So with the different structures of the respiratory system, it actually shows you the nasal cavity, where we actually typically breathe in through our nasal cavity, or we breathe in through our mouth. In gas exchange, that oxygen is inhaled through the nasal cavity, through the mouth. It travels past the pharynx and the trachea. And you see the pharynx and the trachea is in the back of our throat. That's the passageway for gas exchange. And even in the back of our throat, we also had an esophagus. The esophagus that sits in the back of our throat, that's a part of the GI system. But with gas exchange, oxygen enters the nasal cavity or the mouth when an individual is inhaling. Is she in this class? When the individual is inhaling, the oxygen will pass the pharynx as it's passing the trachea, and the oxygen would enter the bronchioles. It will actually enter the lungs, and at the alveoli, I don't see the alveoli on this picture. The alveoli is where gas exchange actually occur. Gas exchange actually occur along the alveoli. And of course, when we breathing in oxygen. When we are blowing out CO2. And CO2 is a waste, multiple wastes that the body produce. Body produce CO2 as a waste, urine, stool, multiple types of waste that the body actually produce. But when we are breathing in oxygen. When we are blowing out CO2. So look at this patient airway. When we're talking about airway, we're talking about more so the pharynx, the trachea. That's your airway. That's what's allowing air to enter. Your lungs having a intact trachea and pharynx. So looking at this trachea, if this trachea begins to constrict, what impact will it have on gas exchange?
It won't be able to expel.
It won't be able to expel what?
The carbon dioxide.
It won't be able to expel CO2. Most of the time it affects the it affects expirations when the trachea constricts, but it would definitely affect gas exchange. Patient will not be able to release CO2. Patient may not even be able to take in enough oxygen. And if the patient is not able to release enough CO2, what acid-base imbalance would that result in? What acid-base imbalance will that result in?
Would it be respiratory acidosis?
There you go. Awesome. And when we think about acidosis, anything that's kind of like acidy in the body, that can contribute to acidosis. And CO2 is an acid. So if you add too much of that CO2 in your body, you got a lot of acid in your body. That type of thing. And you all will learn in Med-Surg 1, patients with diabetic ketoacidosis, which is a complication of diabetes, it can result in metabolic acidosis if a patient is pretty much exercising and they don't have enough sugar to compensate, where cells are breaking down to fatty tissue was actually breaking down to kind of get a body some type of energy, but that actually result in an acid being released. It results in ketones being released, and ketones is another acid. But with the respiratory system, if a patient is retaining CO2, it will result in metabolic acidosis. Not metabolic, respiratory acidosis. And in the event the patient is blowing off a lot of CO2, this patient is hyperventilating, blowing off a lot of CO2, what acid-base imbalance will that result in?
Respiratory alkalosis.
Respiratory alkalosis is correct. And what is a nursing intervention for a patient who is experiencing respiratory alkalosis?
Have
Brown
them breathe in
paper
the bag.
Yes, you need to breathe in a paper bag. Or, hey, relax. I want you to relax. I want you to deep breathe. Come on, relax. Try to relax. Where you are coercing this patient. Doctor may also order, hey, get a patient some Ativan. Patient having an anxiety attack. That's the reason why the patient is hyperventilating. Get a patient some Ativan, and the Ativan will actually work to calm that patient, to actually relax that patient, and it will slow the patient respirations. And just to point out something else, even when looking at the lungs, when you think about patients getting a paracentesis and thinking about a big needle going in a thoracic cavity, you know, you always want to think about the possibility of that needle piercing the lung, because if that needle pierced the lung can deflate. And then to see like the lung is mighty close, you know, it's definitely prominent in the thoracic cavity. Needle can accidentally puncture a lung. So you definitely want to think whenever patients are getting paracentesis, let me monitor your lung sounds. Let me monitor that site that you received that paracentesis to make sure it's not any excessive bleeding, that type of thing, or I don't feel crepitus around the site. And what is crepitus?
It's like crackles.
Yep, it kind of feel like Rice Krispie treats if you palpate that area. If you palpate that area, it will feel like Rice Krispie treats. And you want to report it to the physician. Yes.
So if they have a collapsed lung and we're listening, we're not going to hear anything. What will we hear?
That's correct. Absent lung sounds, because that's an ineffective lung now. So the lung sounds will be absent. And typically with lung sounds, there are multiple lung sounds. When you are listening to lung sounds, normal lung sounds are clear. If you all take your stethoscope, whenever y'all put on your stethoscope, you should be taking the earpieces, pointing it towards your nose and putting that stethoscope in your ear. You should be cleaning your diaphragm and your bell off before and after you use it, because it's considered best practice to utilize that diaphragm or bell on bare skin. So you should be cleaning it before and after using a diaphragm or the bell. But when you are listening to lung sounds, you will actually, when you're listening to lung sounds, you want to take your stethoscope and you start literally at the top of the lungs and you listen. And with listening, you allow the patient to breathe in. That means they are inspiring, and you listening to how it sounds when they inspire, and you allowing the patient to expire. One complete respiration, and then you go to the opposite side. You allow the patient to inspire, and then you allow the patient to expire. And that way, you're able to detect, you know, is it to the point when I listen to the right side, I'm hearing when the patient expire, meaning that they blowing out, I'm hearing wheezing. Patient have expiratory wheezing. When the patient inspire on the right side, I am hearing crackles, or I am hearing what you really shouldn't. I mean, there is a possibility you could hear crackles this high up, but most of the time with crackles, you hear it kind of in the lower lobes of the lungs. But when you are listening to lungs, you will literally start at the top, allow the patient to breathe in and breathe out, go over to the opposite side, allow the patient to inhale, exhale, go down, allow that patient to inspire, expire, go over, come on, breathe in, breathe out, go down, breathe in, breathe out, go over, where you are able to compare each side. You can say upper lobes bilaterally are clear. lower lobes, bilaterally, coarse crackles. And the coarse crackles is where it sounds like you're hearing a little popping. You're hearing a little popping, you're hearing a little bubbling, and which means there's fluid in that patient's lungs. That patient have fluid in their lungs if you are hearing crackling and if you are hearing bubbling. And typically when patients breathe, normal lung sounds are clear. It's just you hear nothing but clearness. You can literally hear the air being inhaled and you can hear the patient blowing out. That's clear lung sounds. But when you hearing patients breathing and it, you know, that type of stuff, no, them lung sounds ain't all that clear. Something ain't right with that them lung sounds where wheezing is audible. Your patient's experiencing wheezing, that is audible. A life-threatening lung sound is stridor. Stridor is considered a life-threatening lung sound. It is a medical emergency. And stridor, it sounds like a really like your trachea really then closed up and where you are trying to force to push that CO2 out and to bring oxygen in. And it sounds like a real loud crowing sound. And I think a year into me being a nurse working at St. John Hospital, I had a patient where she declined. And when I went back to assess her, she was declining, and I went back to assess her, I'm like, oh no, that is stridor. I'm like, that is stridor. And it really was stridor. So it's really important to go on YouTube and look up different lung sounds. I want to hear different lung sounds. I think I have a video posted for you all where it go over the respiratory system as well as lung sounds. But the patient who had stridor, it is considered a medical emergency. And one of the things that I did when I suspected stridor, one of the first things that we do when a patient declines is assess. And of course, with assessment, we want to inspect first. After we inspect, that's when we move forward with what we plan to do. And with that patient, I got a set of vital signs on her. Her oxygen saturation was low. I think her oxygen saturation was like in the 70s. Her respiratory rate was elevated. The patient was tachypnic, and I called the rapid. At the hospital, we call a code if we find a patient unresponsive where they do not have a heartbeat or they're not breathing. That's when we call codes as nurses. We call in a code blue because this patient is not breathing or this patient do not have a pulse. That's when we call a code blue. In the hospitals, we call a rapid when we have a situation where it's completely out of our control as a nurse. There's nothing else I can possibly do for this individual as a nurse, so I'm about to call a rapid, and multiple healthcare providers will rush to that room. But with that particular patient who was experiencing stridor, they end up intubating her. Because to kind of think that stridor, with stridor, your trachea is like really, really tight. It's closing up. It's really closing up where it's hard for you to breathe in. It's hard for you to breathe out. It's hard for you to inspire and expire. So in order for you to get oxygen, to ensure you oxygenated, we can't put a nasal cannula on you. You need to be intubated where you about to get a tube stuck from your nose down your throat or from your mouth down your throat, where this tube being stuck in your mouth through your pharynx, past your trachea, that type of thing to ensure that you oxygenated. And typically when patients are intubated, if they are not conscious, patient is getting restrained. Patient will get restrained for their safety because most patients when they're intubated, if they out of it, when they wake up, the first thing they want to do is snatch it right out their mouth. And it just talks about, in which all of this is considered the airway, but it talks about the upper airway, it talks about the lower airway, which are upper respiratory structures and lower respiratory structures. And the upper respiratory structures, what do they mean when they say nasal pharynx? What is the nasal pharynx?
Is it the nasal passage?
Okay, so
That
nasal
The part of
leads
your
to-
throat.
and throat. Nasal, it makes me think nose. Pharynx makes me think throat. So the nasal pharynx And they actually show you from here to here is considered the pharynx. This is the location of the pharynx, but the nasal cavity is still right here as well. So this will be considered the nasal pharynx. Sometimes, even at one point I was the infection control nurse when COVID first started. So I was doing COVID-19 testing to the whole facility I worked at. A lot of people were complaining. They were mad because of the fact that I was doing a nasal pharyngeal swab. And that's because that's what that the COVID test that we were using called for a nasal pharyngeal swab. It didn't call for a nasal swab, it calls for a nasal pharyngeal. A nasal swab is where I would take the tip of the Q-tip and just run it through your nose. More so just run it through your nose. A nasal pharyngeal means that that Q-tip has to be stuck in this nasal cavity back here to the towards the pharynx. That would be a nasal pharyngeal. So some people were upset. Oh my gosh, you digging too far away. I'm sorry, I know what a nasal pharynx is. That type of thing, where other nurses who were doing it were more so just letting them rub it up against their nostril. No, that's not a nasal pharyngeal swab. Nasal pharyngeal swab is where this actual Q-tip is about to go to the nasal, past the nasal cavity, all the way to the pharyngeal. And it just talks about the upper structures of the respiratory system would include the nose, the mouth, and the larynx. And the oral pharynx, what an oral pharynx, what would that refer to?
The
Mouth and throat.
Yeah, kind of like the mouth and the back of the throat. The mouth and the back of the throat, because this is the oral cavity, but we know the pharynx all the way back here. So physician may order for the you as a nurse, you need to do an oral pharyngeal swab. An oral pharyngeal swab ain't me just letting you put a little spit on this Q-tip or me rubbing your tongue with the Q-tip. No, the oral pharyngeal swab is me getting this tube right back here to your oral pharyngeal cavity. And that's where I'm telling this patient, come on, open up wide, and you sticking that Q-tip all the way back there to the nasal, to the oral pharyngeal cavity. And it talks about the lower airway. The lower airway includes the trachea, bronchi, bronchioles, and alveoli of the lungs. And just look at this as well. In the front of our throat, to say, you actually see this is where oxygenation actually occurs, going down this particular passageway. The esophagus sits right behind the trachea. It sits right behind the trachea, sits right behind the it sits right behind the trachea. So that's why sometimes when you eating something and you like, oh my gosh, you just start choking. And people, sometimes we be saying stuff, really don't know what we're saying, but we know what we're saying, kind of sort of. But people like, oh my gosh, I'm choking because it food almost went down the wrong passageway. Coughing is a defense mechanism. Coughing is a way that we protect ourselves. You know, the way the body protects itself, you cough when something don't belong in that area. That's what you're doing. You getting out something that do not belong in that area. And by these two structures being so close, the trachea and the esophagus, patients are at risk for aspiration. Where, hey, when I swallowed that food, it should have passed and went down my esophagus. However, this food ended up going down my trachea and it entered my lungs. And that's how pneumonia set up. That's how pneumonia set up, where patients get fluid on their lungs and can potentially die. And it just points out the difference with the right and left lung is that the right lung have 3 lobes. Left lung has 2 lobes. And with the right lung having 3 lobes, typically, if I'm listening to lung sounds, I can say, we know bilateral will mean both. Bilateral upper lobes, bilateral upper lung sounds are clear. The right lobe, you will actually put in right middle lobe is clear if it's clear lung sounds. Bilateral lower lobes are clear. But in the event, because sometimes it can be to the point where, hey, this right lung sound is clear to auscultation, while left lung sound, upper lung have the upper lung can have some rhonchi. I'm hearing rhonchi in the upper lungs, and rhonchi is more so where patients kind of have little mucus in their throat, constantly coughing up mucus, and sometimes you can kind of hear the rhonchi in their throat or their upper lung or whatever. So one lung can sound totally different from the other lung, or one portion of the lung can sound totally different from the other lung. So in that event, it wouldn't be to the point, hey, bilateral lung sounds are clear. No, right lung sound is clear. Right lower lung sound is clear, while the left lower lung sound has coarse crackles, that type of thing. And it talks about bronchodilation and bronchoconstriction. What do it mean to dilate and what do it mean to constrict?
Dilate means to open up
Dilate
and
means
constrict
to
means to close.
expand. Yeah,
Which one would increase your blood pressure?
dilation. I'm no constriction. Constriction.
Explain why constriction would increase your blood pressure.
Because when it's constricting, it's causing the pressure to, it's causing your heart to work harder, which increases your blood pressure.
I thought
Is it because it's pushing something out when it's constricting?
it's working. It requires a lot more pressure. Again, I always look at the body as a straw. I look at a lot of things in our body as a straw. So again, picture you got that real big McDonald's straw. You got a McDonald's straw, and picture you went to the gas station, got you some coffee. You got that real little small coffee straw. And with the McDonald's straw, if you put that in your coffee and you get to sucking your coffee, it don't require so much pressure. But when you take that coffee straw, I'm looking at that as being a constricted straw because it's so much more narrow. When I'm sucking through that coffee straw, it's requiring me to use a lot more pressure. So anytime something is constricted, meaning that it's narrow, it's tightened up, it requires a lot more pressure to push through that. It requires a lot more pressure to push through that. But when something is open, it's dilated, it don't require much pressure to push through that. You can push right on through it. So that's the same thing with blood traveling through the intravascular space. When blood is traveling through the intravascular space, if those blood vessels are just open, that blood can just flow through smoothly. That means that the blood vessel was more so dilated. But when the blood vessels begin to constrict and they begin to tighten up or whatever, it requires a lot more pressure to push that blood through. So you do want to know for future classes and just for now with your nursing, when something is dilated, it's opening it up. When it's constricted, it's tightening it up. So you need to be at a picture. If something is tightened up really, really tight, what is it going to take to open that up? A lot of pressure. And it's just talking about the physiology of ventilation and perfusion. And somebody can actually read this page.
Ventilation, hold on, ventilation is the flow of air inside or outside of the alveoli. Oxygen is transported into the alveoli and carbon dioxide is taken out. Perfusion is the flow of blood by the cardiopulmonary system into the alveolar capillaries. Oxygenated blood is directed into the capillaries and deoxygenated blood is returned to the lungs.
And what would happen if tissue perfusion is not occurring?
Cyanosis.
Well, yeah, cyanosis may result, but if tissue, I'm gonna say, if tissue perfusion is not occurring, meaning that, hey, you're not getting oxygenated blood to different areas, eventually that tissue gonna die off.
Necrosis? Oh, okay.
Yeah, the tissue gonna begin to die. And it just talks about oxygenation of the lungs. Somebody can read this page.
When a person inhales, the diaphragm and intercostal muscles contract, creating a negative pressure inside the lungs, and the thorax increases in size for inhalation. When a person exhales, the diaphragm relaxes, the intercostal muscles contract, and the exhalation occurs. Surfactant, a lubricant made in the lungs, keep the alveoli from collapsing.
Okay. And anytime that your patients are using intercostal muscles to breathe, is something wrong. There's something wrong. If patients are using accessory muscles to breathe, there is something wrong where you are able to actually see, hey, you are using your accessory muscles, or retraction is actually occurring, there is something wrong. And it talks about hypoxemia is when there is a limited amount of oxygen in a blood. Hypoxemia can result to patients looking pale or patients looking bluish. And again, with our dark-skinned individuals, more so African Americans or dark-skinned individuals, all the time, due to their lips being darker, that type of thing, you may not be able to recognize cyanosis around their actual mouth or lips. You may need to look at the mucous membrane. Let me look at your gums. That's where you probably can actually see cyanosis. Or let me pull your eyelid down so I can look at your conjunctiva. That mucous membrane is where you can more so see those changes with a darker skinned person. And it talks about retractions. Retractions is considered abnormal. It is when your muscles are being pulled inward. When you inspire or whatever, so kind of the intercostal spaces, you can kind of see where in the intercostal spaces, it's like it's getting sucked it's getting sucked in. It's getting sucked in. And even with the accessory muscles, some patients who is having issues with their muscles of the thoracic cavity, they begin using the muscles in their stomach to help them breathe. And if you actually see it, you will actually be like, hey, it looked like he's using his muscles to breathe from his stomach. It looked abnormal. It looked abnormal. We know as nurses, future nurses, anything that's abnormal occurring with a patient, we need to notify the physician. But you also need to get a set of vitals, because that's going to be one of the key questions the physician going to ask you. What is this patient vital signs? And they're going to ask you for that objective data, you know, the your assessment that you collected. They're going to want to know how the patient feel about it. What is the patient saying? And it just talks about pulmonary circulation, how blood actually flows through the pulmonary system. And it's more so in med-surg too, you all will understand this more, how blood actually flow through the body, more so how blood flow through the heart, but to give you a complete understanding how blood flow through the body, because you all will have to know how blood flow through the heart. And that's going to help things make sense on what happens when a heart fails, or what happens when different portions of the heart actually fail. That's going to make sense for you all. But typically with the flow of blood, oxygen enters the superior, not oxygen, excuse me, deoxygenated blood, meaning that this blood do not have any oxygen. It actually enters the superior vena cava. Once it enters the superior vena cava, it's traveling through the heart, and the heart have 4 chambers. It travels through the right atrium. The upper chambers of the heart, because they have 4 chambers, is the right atrium, left atrium. The lower chambers is the left ventricle, the right ventricle and the left ventricle. So deoxygenated blood which has no oxygen, travels through the superior vena cava, and then it goes into the right atrium. Once it's in a right atrium, it actually passes the tricuspid valve, and we know them valves constantly open and close, and you know valves can be defective. They open and close, and the blood travels through the right ventricle. Once it travels through the right ventricle, this blood then travels through the pulmonary artery. And the pulmonary artery, because arteries carry oxygenated blood, only artery that do not carry oxygenated blood is the pulmonary artery. And veins carry deoxygenated blood, and only vein that do not carry deoxygenated blood is the pulmonary vein. It carries oxygenated blood. So again, the blood travels through the superior vena cava, it passes the right atrium, then it passes the tricuspid valve. Once it passes the tricuspid valve, it goes to the right ventricle, then it enters the pulmonary artery, and this is still deoxygenated blood. Once it enters the pulmonary, passes the pulmonary artery, now this blood is in the lungs where it is being oxygenated, and oxygenation is occurring along the alveoli. Then that oxygenated blood passes through the pulmonary vein. Once it passes the pulmonary vein, it enters the left atrium, and it passes the mitral valve. Then it goes into the left ventricle, and after the left ventricle, the oxygenated blood will actually leave the heart, going through the aorta, where it the oxygenated blood flows into general circulation, and it just keep repeating itself. It flows through general circulation to oxygenate the different tissue. And that is it for this material.